So our next session will be by my very good friend, Davis Ombui. We all know him. He's a physician endocrinologist and senior instructor at Aga Khan. And he's also very good at cooking. So the next time he invites you to his place, please run as Dr. Dindi advised us. Thank you so much.
My wife will not be happy for me to invite people. Good morning, everyone. So we are just going to go through another exciting session. I'm the only man now standing here to give you a talk in the morning after a string of ladies. So we are going to talk about a very interesting molecule. This is not my presentation. Hey, come on, I'm Ombui. Please put my presentation. So basically, what I'm going to do, I'm going to speak about a novel molecule that most of you have already used. And the molecule is called Novo Mix 30. So what I'm going to do is, I want your undivided attention for the first 3 slides. And the reason for that is that these 3 slides are going to save your life, and it's going to earn you 30 CPD points. So, this presentation is supported by Novo Nordisk, it's obvious. So I want you to all look at this graph, this presentation here. What I want you to learn is 2 things from this. If you look at the black line here, that represents a normal physiology of how insulin is secreted in a normal person. So you eat, remember the glucose is never 0 because you need glucose. You eat, it goes up. I'm going to use layman's terms. The glucose goes up, okay? And when it goes up, your insulin lowers this back to some second phase level in the body. So basically you eat, there's a first response of insulin to lower this glucose, then there's a second response of that. Meaning, you need a fast-acting insulin to lower your glucose after your meal, and another protracted insulin level from your pancreas to lower that glucose or to shift it back into the cells, okay? So that's important. If you look at is this maroon? Purple? I'm just a man. So, you can see that in type 2 diabetes, you tend to lose the first response. And that's actually one of the first physiological hallmark of a patient with type 2 diabetes. They tend to lose this. And you see it also delays. The second phase tends to delay. And in type 1, you lose all that throughout the day. So it's important that if you have type 2 diabetes, you need to cover this, and you may have defects in this. So we need to talk about that in the next slide. So look at this. Basically, you eat, and you can see that shaded insulin secretion. It peaks, handles the meals over lunch hour, goes back to a basal level. And the reason for basal level is because when you're not eating, your pancreas, your liver is still releasing some glucose for you to function because your cells need energy, okay? So you need 2 types of insulin, physiologically and externally if you don't produce. So you need one to cover your meals, and you need another one to control your liver from producing excess glucose during the fasting period. Is that okay? Good. Now, I don't know what has happened today. So basically, this was from the UK PDS study. And it was trying to show that in type 2 diabetes, over time, you tend to have a decline in your beta cells. And that is the reason why when you get your patients for the first time, try to tell them that at some point in time, you may deplete your beta cells. And the message I wanted you to get from here is, type 2 diabetes, at some point, you may need insulin, okay? I know there is this notion out there that, oh, once I'm getting insulin, now I'm dying, okay? It's a normal physiological process that at some point your beta cells may be depleted and you may need additional insulin to manage your glucose. So, remember the first slide? So I want you to look at this. So insulins can be categorized into different types depending on how you want to look at them. But for me, I want you to look at it from how I presented the first slide. So there is a fast-acting insulin, the rapid-acting. We have the short, regular short-acting. We have the intermediate, and we have the long-actings. So, and all of you have come across what the rapid-acting insulins are. Those are the insulins you give with the meals to your patients. And we have the long-acting insulins, which you give to manage the fasting periods for your patients. Okay? So remember, what is the defect in your patient will guide you on what kind of insulin you're going to give. So, why then are we bothered about high glucose? And the reason for that is because you tend to get complications related to prolonged and sustained hyperglycemia. This study was done, I think, in a county teaching referral hospital in Kenya. And you can see, just that sustained hyperglycemia contributed much to microvascular complications, as you can see. 58% had neuropathy, 26% nephropathy, 25% retinopathy, and as such. And we know this is dangerous because it leads eventually for these people to have comorbidities that you may now need extra cost to manage, okay? So what we are trying to do is actually just manage this microvascular to prevent also macrovascular complications from arising from these patients. Now, these are some of the studies, and I don't want to bore you with them. But what I want you to highlight is, you can see, if you're trying to lower your HbA1c, you will lower the risk of microvascular complications, okay? And from that previous slide that you've seen, initiating patients to lower the HbA1c will improve the microvascular indices for these patients. And next, you can see that just 1% decrease in HbA1c, you can see the effect it has. You actually have a 14% reduction of risk from myocardial infarction. You have a 37% reduction in microvascular complications, and you have a general 21% reduction in death related to diabetes. So this is a good thing, and just that 1% you can see how much effect it has on your reduction of complications. Same to morbidity and mortality. So look at this. The higher the HbA1c, the higher association all-cause mortality goes. So this just shows you that if you lower this HbA1c, you're actually reducing all-cause mortality for your patient. Now, what is the risk of hypoglycemia? Should we be worried about hypoglycemia? And if you look at this graph here, if you see clearly, some of the major macrovascular events, microvascular events, death from any cause, cardiovascular disease, you can see the hazard ratios, okay? Some of them go as high as 200%, 100% increase in the risk of them having these events. So it is good to also avoid your patients getting into hypoglycemia because you're increasing the risk of these events. So the question then comes back to, which patients need insulin? We all know, it's obvious, type 1 diabetes, they need insulin. But for those patients who are not type 1 diabetes, who are they? So in pregnancy, we know the only two medications which are allowed, so it's insulin and metformin. We know that in patients who are on high glucocorticoid therapy, we know patients who are going through any acute form of illness in the hospital. We know the patients who have come in with acute complications of diabetes. We know the patients who have failed to achieve glycemic control on at least 2 or 3 oral therapies. And those who have intolerance or contraindications to oral hypoglycemic agents. And who are at risk, especially when it comes to hypoglycemia. So basically the elderly, as you know, we have the young, we have the pregnant women, those who have an awareness of hypoglycemia, and those who have comorbidities associated with them. So, the guidelines. So this is the 2024 ADA guidelines, and the question is, where does insulin fit into this picture? If you look, it's the same slide for yesterday, right? So you can't see anything. So you'll just still believe what I say. You're going to look at the comorbidities and determine which is your first medication that you're going to use. But my medication is somewhere here. And the reason for that is your insulin is a really good lowering glycemic agent, okay? So if you're looking for something efficacious to lower your HbA1c and you're not worried about weight and you don't have any of these comorbidities, then that is the most appropriate insulin to use. And this table dictates about what kind of injectable therapy are you going to start your patient on. So with the advent of new molecules that we have, most guidelines recommend that if you can start with a GLP, better, because one, the GLP will lower your weight and it's also efficacious agent in lowering your HbA1c. But in the case that you're using your GLP-1 and you're still not meeting your targets, you are actually encouraged to add on insulin. And we are going to talk about which insulin are you going to add and at what dose and all those things. But the current recommendation, you can start with a GLP and you can add on insulin later on to try and optimize your treatment. I'm sure most of you who have been in the diabetes space for some time have come across this graph. Basically, this graph is going to try and explain one thing. If you look here, going on the right side, the higher your HbA1c, the biggest contribution to that is the fasting plasma glucose. On the lower side, if you're not hitting your targets, the biggest contribution to your HbA1c is actually your postprandial glucose excursions. And that's important because you'll see most guidelines telling you that if you're not optimizing and your HbA1c is high, start with a basal, okay? But I'll tell you another trick as we go on. So, you started your basal, okay? And you're wondering, now how do we move on from there? Remember, when it comes to the decision about how to start insulin, it starts with the question, does the patient need insulin? That's the first question. The second is about which insulin are you going to use? So there's the process. You initiate, you optimize, you intensify. Okay? So we'll go through those things. So you've initiated your patient on your basal bolus, but you've not optimized. So you're wondering, your HbA1c is still not on goal, and you've hit 0.5 units, then you need to now intensify. You have HbA1c that is elevated, but despite the normal fasting plasma glucose, or the other indices are still not within range. So then you now need to make a decision as a clinician. How am I going to move to the next level of treatment for my patient? And I'm going to introduce here something that you all know. We have mixture insulins, okay? We have human mixture insulins and we have analog mixture insulins. Basically, the old and the new, okay? And the old was associated with more side effects. So increased risk of hypoglycemia, increased risk of weight gain, and such things. But the newer analogs, as you can see here, they have written here, this premixed insulin has, for example here, 30% insulin aspart and 70% insulin aspart protamine. And you wonder, why aspart? It's because you've protaminated the aspart, meaning you are protracting its action to make it longer acting, okay? So it's the same aspart, but you've increased its duration of action for it to work for a longer time. So it's the same molecule, one behaving as fast acting and the other one behaving as a long acting, okay? So that is why you have it as 30% and as 70%. So the 30% to act on your immediate prandial period and the 70% to act as a long acting insulin. Now, I'll jump this for the reasons because I'll come back to it. I want you to look at this. And this one is trying to compare for you two insulins that you know. One of them is the Mixtard 30, and the other one is Novo Mix 30. So as I had already indicated, the Mixtard 30 is the human insulin, which is an old insulin. I'm not saying it doesn't work. And there is also a Novo Mix 30, which is an analog, more safer insulin. And look at the profiles. If you look at the blue, which is the Novo Mix 30, it goes up nearly the same way as your physiological insulin. Okay? And it sort of slides down better and even in a way sensible enough, together with the physiological handling of the insulin. If you look at the 30, the human mixture, you can see that it has a delayed action. It doesn't peak as much, okay? And it goes up a bit during the second phase. So that means, one, it won't be the best in lowering your prandial insulin as good as the Novo Mix 30. And it will also delay its action in the protracted phase of your post-meal. So that means the Novo Mix 30 is safer, works faster to lower your prandial insulin, and also blends well after your post-meal, meaning it's a better mixture as compared to the human insulin. And you can see that it has actually a 55% reduction in hypoglycemia as compared to the other human insulin that you knew. So, who are the ideal candidates for Novomix? Because we've talked a lot about it. One, you can see those who need simplified insulin formulations. And these are people who are, for example, elderly, people who have dexterity issues, okay? People who also just by themselves don't prefer to have many insulin injections, okay? Number two, those people who have a fixed meal pattern. So those people who you know are like soldiers, they eat maybe at fixed times and their meals are actually ascertained to be amount or to be in a certain fixed amount of calories. Now, those who require postprandial glucose control and have difficulty managing complex insulins. So I'll go back and give you how I do it. If you have a type 2 diabetes in your clinic, and this is the first time you're seeing them, ask them to give you a 6-point reading. Look at their fasting, look at their pre-meals, look at their post-meals, give them at least to do it for 3 days. And you will be surprised because our meals, our Kenyan meals, are heavily carbohydrate meals. And you will find that there is a big excursion of the glucose after meals, okay? So that is one of those indications where you may need something to cover the prandial and something to cover the fasting state. So it's a good indicator to show you what kind of insulin do you really need for your patient. I know you'll put the dietetics inside for you to help you control your meals, but this data will help you actually handle your type of insulin that you're going to give for your patient. And it was just as short and sweet as that.